I'd like to welcome our speaker, Shelley Moats. Shelley is a pediatric audiologist with the Norton Children's Medical Group. She has nearly 30 years of experience providing comprehensive, family-centered pediatric audiology services. She provides diagnosis and treatment for childhood hearing loss, including hearing aids and cochlear implants. She is active on numerous committees to promote quality pediatric audiology services at both the state and national level. Thank you so much for joining us today.
Thanks for having me. I'm going to try and share my screen so we can get this going here. Bear with me for just a second. I just lost it. There we go. Here we go. All right, McKenna, can you see my screen?
I can.
Okay, so we're going to get started. Hope everybody is excited to spend a lunch hour here. Thank you for coming. I have a lot of content, but I'm a pretty fast talker. So hopefully we'll be able to get through all of our information today. And I think McKenna is going to be monitoring the Q&A for questions, but I'm just going to go ahead and get started. So we are going to spend, my thing is not advancing, bear with me. Hang on, McKenna. There we go. All right. These are my disclosures, nothing financial. I am, as you can see, involved in several state and national organizations related to childhood hearing loss. Today, we're going to talk a little bit just about the prevalence of childhood hearing loss and how many a pediatrician might expect to see on their caseload over the course of their career, how audiology follow-up works after a failed newborn hearing screening in the hospital, why medical workups are really important for patient care when a permanent hearing loss is diagnosed in an infant or a child. We're going to spend some time talking about congenital CMV infection. And lastly, we're going to touch on the importance of being good partners to each other in the care of children who are deaf and hard of hearing. So when we talk about national benchmarks for what we call early hearing detection and intervention, or EDI is our acronym, we like to talk about 136. What that means is that our goal is that all babies are screened for hearing loss by 1 month of age. They receive a diagnostic evaluation by 3 months of age if they fail their newborn hearing screening, and that children who are identified through that screening and diagnostic process as being deaf or hard of hearing receive early intervention initiated by 6 months of age. We in Kentucky are doing a pretty good job with 1. We're doing a so-so-ish job with 3, and 6 is kind of our struggle, which we'll talk a little bit about as we go through the presentation. But over the course of time, nationally, we hope to move that 136 goal to a 123. Kentucky currently screens for 58 different conditions at birth, and hearing loss is actually the most common. National statistics put permanent childhood hearing loss at 3 in 1,000 live births, and monitoring of Kentucky data puts us right in line with that statistic. The current number of confirmed ID hearing losses in 2024, because our data gets reported to the CDC a year behind, as of today is 76. You can see that 156 babies, we think, based on that estimate, were born in Kentucky with hearing loss. So we have a gap of about a 50%, what we refer to as loss to follow-up. As far as the newborn hearing screening, for well babies, the process is different and streamlined. The process of screening varies in Louisville depending on what hospital the baby is born at. So at both Norton facilities and at Baptist Health LaGrange, if a baby fails their screening twice in the hospital and they're a well baby, they have no NICU stay, they have no other risk factor, which we'll talk about later, those babies come to audiology for an outpatient rescreening. The babies that are born at Baptist East, Clark Memorial, and King's Daughters, currently those outpatient rescreenings are done at the birthing hospital. So after the baby is discharged, they'll go back to the hospital for their outpatient screening. We have, I think, last year, just shy of 500 babies maybe born at home in Kentucky. Our EDI, Early Hearing Detection and Intervention Program, that's run by the state, is working on a midwife initiative to provide screening equipment and training so that babies who are born at home can also receive a hearing screening by 1 month. We have some rules around how we screen and rescreen. There are only 2 screenings per ear allowed prior to the baby being discharged from the hospital. In order to be considered a pass, both ears have to pass the same screening. Like we said just a minute ago, babies are permitted to have 1 outpatient rescreen if they're a well baby with no risk factors. NICU graduates are not eligible for outpatient rescreening if they fail that second screening in the hospital. They're immediately referred for diagnostic ABR due to risk factor concerns. If either ear or both ears fail on that final screen, full diagnostic evaluation is required. Audiologists are currently reporting screening results for babies born in Kentucky in the KY Child system. We're going to transition to Vital ID sometime in 2026. That keeps getting pushed back. Indiana has a system called EARS for tracking their newborn hearing screening results. As far as the diagnostic testing, oftentimes when parents come in for a diagnostic eval, they'll say, oh, well, my baby only failed in the left ear. Why are you testing both ears? Our policy based on state and national guidance is to test both ears, even if the screening was only failed in one ear. We include a battery of different tests to evaluate the different parts of the auditory anatomy so that we can paint a picture of what's going on with the hearing system. The most significant part of that testing is called an auditory brainstem response evaluation, or ABR, which is essentially a mini EEG strictly of the auditory system. We can use that testing to estimate hearing thresholds, but it is not a true test of hearing because we're only evaluating sensitivity through the level of the brainstem. My slide will not go. There it goes. There are certain conditions associated with risk factors for either late onset or progressive hearing loss. And part of what our Kentucky EDI program does through a form that is used by hospitals, which you'll see in just a minute, is they track risk factors for individual infants. That allows us to provide, as a program, to provide resources to families of infants who fail the screening and are ultimately diagnosed with hearing loss. It's used for PCP education. Many of you have probably received letters in your office on infants who have failed the newborn hearing screening. That's one way that we try to monitor loss to follow-up and reduce that problem. For babies that have risk factors for late onset or progressive hearing loss, we use that data to track those babies. The EDI program has coordinators who will reach out to families to make sure that babies are getting the needed follow-ups. And one thing that's new within about the last year is that if a baby fails their newborn hearing screening in the hospital in Kentucky, they are automatically screened for congenital CMV infection. And there is now a letter that comes from EDI to the PCP to talk about whether or not there is a diagnosis of congenital CMV infection. On the right of your screen here, you see this is the form that is used in the hospital to talk about risk factors. It's recorded, the screening results are recorded on the same form where the risk factors are listed out. This was updated in 2022 based on some information that came out from the Joint Committee on Infant Hearing, which is a national stakeholder group, in 2019. And our Kentucky EDI Advisory Board further clarified the risk factors to assist PCPs in helping to make sure their patients are getting the correct management by establishing 2 separate categories of risk. So this document that you see here is on the EDI website through the state. It's a really nice quick guide, talks about what the risk factor is, any special considerations, when should the initial evaluation be completed, which is really important, dependent on the risk factor. And then what necessary follow-up is required. This document is updated periodically as new information from the Joint Committee on Infant Hearing and other organizations is released. But it is a nice little one-pager that you can print, post, super helpful. There we go. So what we have, our division, we have red risk factors and black risk factors. The red risk factors are classified for conditions that require emergent attention and follow-up. This could be related either to a high prevalence of hearing loss due to a certain condition. For example, if a baby has atresia or microtia, they are going to have permanent hearing loss nearly 100% of the time. And so those babies need really quick follow-up. Or there is a risk of rapidly progressive hearing loss that would require immediate confirmatory testing, such as congenital CMV or Zika virus infection. You'll notice that a red risk factor is parental concern for hearing loss. We think that parents are generally pretty smart about their babies, and we will often get calls where they say, hey, my baby, maybe passed their newborn hearing screening, but I'm really concerned that they're not hearing well. And we are picking up some kids that way, maybe not necessarily with a permanent hearing loss, but maybe with a transient conductive hearing loss due to otitis media, for example. And so we like to take that parental concern very seriously, would much rather do an evaluation and say, hey, guess what? Everything is normal. And then make sure that parent feels reassured than to, say, oh, well, you passed your newborn screening. Everything's fine. So we'll just, kind of move along. The other thing that is interesting about these red risk factors is that many of them carry a risk for progressive sensory neural hearing loss. And that's important, especially for audiology management. Our black risk factors, if a child has one of these risk factors listed on the screen and they pass their newborn hearing screening in both ears, we require a follow-up audiology evaluation no later than 9 months of age. We like to say 9 months corrected age because if we have a baby that's very premature, let's say we've got a 22-weeker and we do them at 9 months, not corrected, that baby may not be able to participate super well in our testing that we do in the office. And what we like to try and do is we like to avoid sedating kids for ABR testing whenever we can. So we say 7 to 9 months corrected age is our ideal timing for that follow-up test. And then we recommend additional testing as needed based on the specific risk factor and the patient history. For example, certain syndromes associated with hearing loss may dictate ongoing monitoring if the hearing loss associated with that syndrome diagnosis is late onset or progressive. Some NICU babies with just that one risk factor of staying in the NICU for greater than 5 days, maybe it's a feeder grower, born a little small. Oftentimes we see those babies in clinic at that 7 to 9 month point. They pass out and we're good. But we definitely want to still complete that evaluation because sometimes we get a little surprise. It's really important on the audiology side for us to be really taking a good look at that patient specific history, asking lots of questions about development, history of ear infections, et cetera, so that we can make recommendations for appropriate follow-up after that 7 to 9 month evaluation. There we go. So let's switch gears a little bit now that we've talked about screening, and let's talk a little bit about some of the risks of undiagnosed and untreated permanent childhood hearing loss. What research tells us about brain development causes audiologists to classify permanent childhood hearing loss as a neurodevelopmental emergency. The reason for that is because the auditory cortex is pretty wired by the time a child is about 3 years old. So if we are not getting good auditory stimulation to the brain during that birth to 3 period, our long-term outcomes are just simply not as good in terms of speech and language development. Certainly, you can imagine that if a child doesn't hear well, they're going to have issues in the classroom. There's a big link between hearing and reading. And oftentimes we see our kids with hearing loss struggle a little bit more to learn to read, even when they're getting great intervention and have appropriately fit hearing technology. Sometimes that transition to the word on the page is more difficult because the sound perception is more difficult. Sometimes kids with hearing loss have a little bit more trouble making friends because they miss out on social cues. There's a higher incidence of bullying in the deaf and hard of hearing population. And certainly we've had kids come to us because they've come to you as PCPs first, and they say, oh, like, we're getting reports home from school that Johnny's not hearing very well. And you screen Johnny's hearing and Johnny fails, and then you send him to us and Johnny has a hearing loss. And but the label that they've been given is, oh, he's inattentive, or he's not paying attention, or he's not listening, or he has behavior problems. So these are all good reasons to refer to audiology if there is some kind of a concern. So early intervention is key. I am trying to figure out how I can pin the Q&A to my screen in my slideshow view, and I cannot figure that out. So McKenna, I might need your help here to shout out. I would just like to ask somebody in the group, how soon do you think an infant with permanent childhood hearing loss can be fit with hearing aids? Can somebody throw me a guess on the age? And McKenna, I might need you to say it out loud if somebody puts it in the chat.
Yep, I'm watching the chat.
Thank you so much. I can't see you
Someone
either.
says birth.
Birth. Yes, that is an awesome answer. I love that. My personal youngest is 2.5 weeks of age. That was a baby from a family that had 2 older siblings with hearing loss. So when the baby failed the newborn screening in the hospital, mom called and said, we're going home tomorrow. Can you see us? And I said, yes. And then we just fit an infant that's about 5 weeks old with hearing aids yesterday. My next question is, how soon do you think an infant who meets candidacy criteria for a cochlear implant, how soon do you think that can happen? Any takers there? That one's a little tougher, I think.
Nothing yet.
Okay. Does anybody want to take a wild guess?
No responses. Oh,
That's
3
okay.
months. 3 months.
Well, that is actually a little bit on the early side. There are 3 FDA-approved manufacturers for cochlear implants in the United States, and one of the companies within the last several weeks has received FDA approval for their device down to 7 months of age. Previously, it was 9. We definitely are trending backwards. In Europe, it's 6 months in most countries, because what the research tells us is that the sooner we can provide auditory stimulation to children who are deaf through a cochlear implant, their long-term speech, language, and academic outcomes are better. I'm really happy to see that people think we can do this early. I oftentimes think there's a misconception that we can't. So that actually is really exciting to me. Let's shift a little bit now into why medical evaluations, actually, time out. Let me back up. I did not see that. How soon do you think an infant with permanent childhood hearing loss can begin to receive early intervention services like speech language therapy? I'll ask one more question before we move on.
Birth. The response was birth.
Birth, and that is absolutely true. We have in our department 2 speech language pathologists who only work with kids who are deaf and hard of hearing. When we diagnose a baby, those are the first people that they meet before they leave our clinic, because we want to establish that relationship early on. And the outcomes, when the system works like it's supposed to, when we hit that 1 and we hit that 3, and we're providing hearing aids and early intervention, Our kids have really fantastic outcomes. I have been doing this long enough now that I have patients that are in college, which is very interesting to me. I have a patient who is a music major and plays 6 instruments. I have a patient who is an engineering major at an Ivy League school. We have college athletes. Our kids could do really amazing things when we provide them with the right support and we're meeting our timelines. So now we're going to talk about medical workups. This is a really big area of interest for me. So listed on the slide are some workups that are recommended by the Joint Committee on Infant Hearing group, which includes both primary care providers, audiologists, and ENT. These evaluations, I think, are really important. There was a study done with 270 children with severe to profound hearing loss. And they looked at imaging results, like how did that shake out? They got a 24% yield with an MRI abnormality and an 18% abnormality hit rate with the CT. If you do genetic testing for the most common genetic mutation that causes hearing loss, which is called connexin 26 or GJB2, that has about a 20% diagnostic yield. So if you kind of do the math on that, if you're doing MRI and genetics for the most common types of hearing loss, about 50% of the time, we're going to get an etiology hit, which is really helpful for families because it helps them know what to expect for their child. Other lab studies, it used to be a lot of like EKG, autoimmune, urinalysis. Those lab studies can be important for certain kinds of patients, but they have a really low diagnostic yield. In that study of 270 kids, there was less than a 2% hit rate for all of that. So the trend now is to focus less on those other lab studies and focus more on imaging and genetics. An example of one particular case where ordering, say, an EKG could be important. If you have a child that is profoundly deaf and they have a family history of unexplained sudden death, then that particular patient should receive an EKG to rule out long QT syndrome, which is a marker for Dravet-Lang-Nielsen syndrome. Ophthalmology, also super important. Kids with hearing loss need to see. They need to see because they will rely on visual cues. If they don't see well, we need to have that addressed. If they have a medical condition, for example, if they have a diagnosis of Usher syndrome, that's also important to pick up on early, so we can provide support to that family so that we can make sure that not only is that child hearing well, but they're also seeing as well as they can. So what's the breakdown of causes of hearing loss? About roughly half is environmental. Congenital CMV is a big one. Estimates are that about 20% of all hearing losses present at birth are from congenital CMV. About not quite 20% are genetic syndromic, meaning that they have a hearing loss and some other medical or developmental condition. And then the remaining hearing losses are genetic non-syndromic, which is pretty common. We had mentioned connexin 26 a couple slides ago. That is the most common form of genetic non-syndromic hearing loss. So families are going to look at us and say, gosh, well, there's nobody in my family that has a hearing loss on either side in childhood. And we're going to say, yeah, that's actually correct. Most inherited hearing loss is non-syndromic. Here's another question for the group. What percentage of kids identified with permanent childhood hearing loss do you think receive genetic testing? Any guesses?
Not yet.
Say that again.
No guesses yet.
No guesses. Would you be surprised if I told you it's less than 20%? It's really low, which is it's concerning. I think there is a little bit of a misperception on the part of the family. Well, I have a baby with hearing loss, but it doesn't matter. Like if we have another baby with a hearing loss, like we'll know what to do, or this is our last child, so we don't really need to know. But genetic testing is about so much more than family planning. It can provide information on the etiology, which can help in terms of like understanding future risk of having a child with hearing loss. But the main thing that we focus on when we talk to our families about genetic counseling and testing is that we can potentially identify if your child has a risk for a hearing loss that is going to progressively worsen over time, so that we can be proactive rather than reactive in our management. It can also identify syndromic conditions where other medical issues might need to be evaluated or monitored. One that we encounter often in the clinic is Pendred syndrome. You have a permanent hearing loss. Many children with Pendred syndrome end up needing cochlear implants. And there's also an increased risk of thyroid disease. And so those kids that are diagnosed with Pendred syndrome need to have periodic monitoring of their thyroid. And the thing that I think is really cool about genetic testing is that it's constantly evolving. So if we have a family that undergoes genetic testing today, and they do a panel that tests for, a lot of the panels will test anywhere between 200 and 400 different genes for congenital hearing losses. They'll come back and say, well, we didn't get a hit. And we're like, okay, but if you do that testing again, in 5 years or 10 years, there may be a new variant that's been identified and you may be able to get information at that point. So it's definitely not a one and done. And gene therapy for hearing loss is also evolving. There is a company called Acuos that is currently testing a gene therapy for a very specific genetic mutation called OTOF, which causes a type of hearing loss called auditory neuropathy spectrum disorder. There has been some success in the trials in children with restoring hearing. So that's really exciting. So we encourage all of our patients to have genetic testing if their child is identified with permanent hearing loss. I want to flip over now and talk about congenital CMV infection. This is the most common non-genetic cause of hearing loss. Some statistics on CMV. 1 in 3 mothers who contract CMV infection during their pregnancy will pass the infection to their fetus through the placenta. 1 in 200 children are born with congenital CMV. 1 child per hour with congenital CMV is permanently disabled. And I think the most startling fact to me is that only 9% of women of childbearing age know what congenital CMV infection is. How do you get it? You guys probably know a lot about this because you're in healthcare. So basically, we want to use universal precautions, wash our hands, don't share food, don't share cups, don't kiss on the mouth, wash your hands really well after diaper changing, things like that. It is present mostly in urine and saliva, to a lesser degree in semen, breast milk, and tears. Daycare kids are little CMV spreaders. So oftentimes when we have a baby that has congenital CMV, they have an older sibling at home who's been in daycare, because kids are germy, as we all know. Some of the prenatal signs and symptoms of congenital CMV infection are listed on this slide. Sometimes if the infection was acquired in the first trimester, or the condition is very severe, some of these abnormalities can be picked up on your 20-week anatomy scan. But for infections that come later or are more mild in nature, this is not always the case. So oftentimes the only sign of congenital CMV infection is this cute little baby on the top right with the little ear cups on, is a failed newborn hearing screening at birth, which is currently referred to as asymptomatic congenital CMV, which kind of makes me crazy because hearing loss is a symptom of CMV, but that's currently how it's classified. The other statistic that feels a little nerve-wracking to those of us in pediatric audiology is that 90% of babies with congenital CMV do not show any signs or symptoms of the condition at birth, and many will have normal hearing in the very early stages of their life and will pass their newborn hearing screening and then maybe show up in our clinic when they're 2 or 3 or 5 and have a significant hearing loss that needs intervention. Lots of potential long-term sequela of congenital CMV infection, just again, depending on at what point in the pregnancy the CMV is acquired and passed. You can see some of those sequela listed here. Obviously, hearing loss is the most important to us in audiology world, but all of these other things like vision loss, developmental delay, behavior, sensory issues also impact that child's audiology care. And so it's really important for us to have an understanding of kind of that whole child view of congenital CMV infection and its impacts. Interestingly, the American Academy of Pediatrics fairly recently published an article that indicated a diagnosis of autism is about 2.5 times more likely in a child who is diagnosed with congenital CMV infection compared to a non-congenital CMV population, even after adjusting for factors like birth year, gender, and region of birth. So in terms of the hearing loss, how does this kind of roll down? 10 to 15% of babies with congenital CMV infection will develop hearing loss. Again, almost half of those kids who have congenital CMV infection will not present with significant hearing loss during their first month of life. In our world, we think this is a really great argument for universal CMV screenings as opposed to the targeted screening, which we currently have in Kentucky that I'll talk a little bit more about in a minute. To recap, congenital CMV causes a good chunk of congenital hearing loss and about a quarter of all permanent hearing losses by age 4. And of the children with congenital CMV that have hearing loss, about half of those kids will have progressive hearing loss. And many of these kids, if they start out with hearing aids, they wind up with cochlear implants in pretty short order. So I want to talk a little bit more about the progressive hearing loss. In order for audiology to monitor that risk, we need to know that that baby is CMV positive so that we can screen, diagnose, monitor. CMV associated hearing loss can be present at birth, like we mentioned, come later. It can be in one ear or in both ears. There is treatment for the hearing loss portion of congenital CMV. The Red Book indicates that kids can be treated with valganciclovir. Previously, valganciclovir treatment was reserved for moderate to severe cases of congenital CMV, but recent revisions are now allowing that to be used with children who just present with hearing loss at birth. And I want to talk a little bit about our screening law. So this is Bella. Bella was one of my patients. She was born with congenital CMV. She failed her newborn screening. She had profound hearing loss in both ears, multiple brain-related abnormalities causing seizure disorder, which ultimately took her life. She died from complications related to CMV infection in 2020, just after her 3rd birthday. Bella loved to hear. She loved her cochlear implants. I have this really fantastic video of her during her initial activation where we were doing some testing to get the implant set up. And every time the stimulation came on, she would just give this huge belly laugh. She would not, if she woke up at night, she would not go back to sleep unless mom and dad put her cochlear implants back on. Bella's mom, Sarah, was the champion of passing our current legislation, which passed and was signed into law in 2022. And Sarah continues to support our CMV families in Kentucky through her role as a parent guide in Kentucky Hands and Voices, which is a parent support organization for children who are deaf and hard of hearing. And she's also a Community Alliance Chair for Kentucky for the National CMV Foundation. So through Sarah's hard work, Bella lives on and won't be forgotten. As far as our law goes, the initial bill proposal was for universal CMV screenings. The stakeholder group was advised by the legislators that that would not pass out of committee. So we backed up and came through with a targeted screening, which includes failure of newborn hearing screening, as well as a list of any other conditions that are commonly associated with congenital CMV infection, like petechiae, abnormal blood work, IUGR, low birth weight, things like that. And that's our law that was passed in 2022. Implementation is ongoing. So the components of the law are the targeted screening. Physicians and health facilities are to provide information on CMV to pregnant women or women who may become pregnant. And physicians and healthcare facilities can use educational materials that were developed by the Department of Health. And currently this exists on their website. If you try to find it, you have to go like 4 pages in and it's kind of buried. So our EDI advisory board decided to take matters into our own hands, and we partnered up with our infectious disease colleagues here at Norton and also at UK. And we developed a CMV toolkit. And the blue and white document that you see on the left side of your screen is that toolkit. It talks about the screening and the process of what happens when you get a positive result on a different kind of test, urine versus saliva, for example. Talks about other signs and symptoms of CMV, how frequently hearing is monitored. And then on the right is a fact sheet on congenital CMV infection for healthcare providers. So how are we screening in Kentucky? UK currently screens all of their NICU babies, as well as babies who fail the newborn hearing screening as outlined in the law. We do have a reporting method in place. Unfortunately, our bill was an unfunded mandate, and so the responsibility of tracking has kind of fallen back to the EDI program. So we are relying on facilities to report. We are relying on audiologists to report. I know our team monitors those results when we get a baby in that has failed the newborn hearing screening. So we're trying to kind of help our EDI colleagues track how many kids. We hope to come back in the next few years or so and update the legislation to implement some better tracking and reporting. Oop, I went too far. Hold on, there we go. So how are we screening? Currently, what's happening within our Norton system, we are babies who fail their newborn hearing screening while they're in the hospital get a cheek swab. If CMV is picked up, our ID group is using urine PCR as confirmatory because it is the gold standard for diagnosing congenital CMV. There are some states that are using the dried blood spot for screening. There's a lot of research that's going on in this area. It would be where some of the data is really promising. And obviously this would be a really easy way to do it because every baby is getting a dried blood spot and they can be stored for a little while. So we're hopeful that the data that come out on using the dried blood spot continues to show that it is a viable method. If you are a woman of childbearing age and you want to know your current CMV status, you can have immunoglobulin testing. That will only tell you if you've never been infected or if you've been infected in the past. It doesn't tell you if you have a current infection or reactivated infection. So there are some drawbacks there, but we get asked that question by parents more often than you would think. Some national trends in screening. Minnesota has been doing universal screening since 2021. Connecticut passed a bill in 2025. New York is currently doing a pilot study on universal screening. Targeted screening, we're one of a good handful of states that are doing a targeted screening based on newborn hearing screening testing. There are education requirements in a handful of states as well, including Kentucky. There are some proposed bills that are kind of in the works. We hope that our neighbor to the north, Indiana, will pass a law in 2026. We'll see how that goes. There also has been some federal legislation introduced, but that, as of now, has not moved forward. So how often do we need to monitor the hearing status of kids who are diagnosed with CCMV? The Joint Committee guidelines published in 2019 really focused mostly on that initial diagnostic evaluation. So if you have CMV, you get an ABR by 3 months of age, and then annually thereafter or more frequently if concerned. I was part of a subcommittee with the American Academy of Audiology, and we did some lit review and wrote a white paper in 2023 where if a baby has congenital CMV infection confirmed, they are evaluated every 3 to 6 months for the first year of life, every 6 months until age 3, and then annually until age 6. And at that age 6 point, if there's still no hearing loss, then they are discharged from monitoring. Our kids who have confirmed permanent hearing loss from CMV are monitored kind of on that more rigorous schedule that we follow from the first year through age 3. This is something that we talk to our parents about a lot. How can you, I feel like prevent is maybe not the right word. I feel like risk reduction is maybe a better way to say it, but this is a list of some basic things that you can do to reduce your risk of contracting CMV while pregnant and passing it to your unborn baby. And really, it's just universal precautions. So that's my CMV spiel. I have a lot of strong feelings about the importance of that patient population because it affects so many of our families. But I want to switch gears now and talk a little bit about how we can all collaborate together to best serve our kids who are deaf and hard of hearing. So I have another question that I'd like to pose to the group. How many kids with permanent hearing loss do you think you'll see on your caseload as a PCP? There's not any formal study, but I have some anecdotal data, so I'm curious to see what people think.
One response is 20.
20. I would say that for the pediatricians that I've talked to, work with, that my colleagues have talked to, work with, it's really like 5 or less. It's just, you know, your incidence is low, they're kind of spread out, but even 20, like that's for all of the kids that you see, it's not a lot. You know, so it's not going to be a super high incidence issue that you're going to encounter every day in your clinic. And so sometimes I think that can make management feel a little more daunting. Like, do I need to make any extra referrals? You know, does this kid need to see ENT? How do I collaborate with the other providers that are serving this child to make sure that they're getting everything that they need? And I think we'll talk a little bit separately about ENT consults. And this is more general, not just for kids with permanent hearing loss, but the American Academy of Otolaryngology updated their guidelines for ear tube placement in 2022. And I have a little summary of that document that I want to share. But as far as our team, if you have a kid that comes into your office with a hearing device, or you know that they should have one, we know that use during most waking hours of the day provides the best outcomes long-term for speech, language, and academic achievement. If you need to remember a short phrase, we like to say eyes open, ears on. That helps just to remind that this is an important part of that child's day and their access to communication. If you are ever concerned about a patient, please reach out to myself or any one of our colleagues. If you have a concern, we are pretty short-staffed right now, like most people. But if there's compelling evidence, we're gonna move things around if there's a high degree of concern to get that child seen. And then one way that we can hope we can count on the pediatrician groups is to help us reduce our loss to follow-up from newborn hearing screening by confirming that that baby has seen audiology. In pediatric audiology world, I think like in most things pediatric, our no-show rates can be pretty high, but we feel like most of our kids are going to make it to the pediatrician at least once in a while. So just be in the habit of looking back at their record, saying, oh, I see that, Susie failed her newborn hearing screening. Did you ever get a follow-up for that? Oh, you didn't. Let's go ahead and get you scheduled for that today. It takes a village. Loss to follow-up rates in Kentucky are poor. And so we're just trying to close those gaps any way that we can think of. As far as ear tubes, I think there's a lot of discussion about this. I know in our audiology group, because usually by the time kids get to us, they've had chronic ear infections, they have some speech delay. Most of the kids that get to us end up going to ENT. But AAO recognized some of the developmental impacts of recurrent or chronic otitis media and its associated hearing loss. And in 2022, they updated their guidance for children who are considered at risk. So a kid with a permanent hearing loss, the threshold for ear tube placement, if they have recurrent ear infections, is going to be a little bit lower because they're going to have additional conductive hearing loss on top of their permanent hearing loss. Any concerns about speech and language delay, kids with autism, kids with Down syndrome, kids with vision issues, developmental delay, the whole list is right there. They also updated the hearing loss categories, which I actually found to be really helpful. Prior to this update, the AAO considered normal hearing for children to be 25 decibels and above. We in pediatric audiology world know that kids require a little more volume to do well developmentally and acquire their speech and language. And so the defense for normal hearing in the pediatric audiology clinic is 15 dBHL. And AAO did update their guidance to reflect those more strict levels based on literature review and long-term outcomes. So what's our takeaway today? I hope that you have all learned a little bit of something about how follow-up on failed newborn hearing screenings is really important for your patients. I hope I provided you with some resources that you can go to take a look at what the process is supposed to look like. I think it's important to know that about half of permanent childhood hearing loss is environmental, and CMV infection present at birth is thought to be the leading cause of that group. About half of our hearing loss in kids is genetic, with the majority of those kids being what we refer to as a vanilla hearing loss kid. They just have a hearing loss. They don't have any other medical or developmental condition. And it takes all of us. Newborn hearing screening came to be right around the start of my career. And it's been really fascinating to watch the evolution over the years and to see the things that we can do now that we couldn't do 30 years ago. So with that, I am happy to take questions. My email is on this slide. I'm always happy to chat about hearing loss in children, always happy to chat about questions that you have. Does anybody have any specific questions that they'd like to ask today? I can now see the Q&A, McKenna, so that's good.
Okay, great. Can you tell us about the hospital screening and number of tried?
Okay, so I think I understand what you're asking. And so the maximum number of times that a child can be screened in the hospital is 2. That is the limit. That is in reg. That is it. Well babies can receive an additional outpatient newborn hearing screening. NICU babies who fail that second screening in the hospital are automatically referred for diagnostic ABR. And we do kind of see this. We do get parent reports where they'll come in and they'll be like, they screened my baby 4 times, and we're like, oh no. We definitely don't want to do that. And we try to partner with our EDI program. If we get those reports, we kind of will go back and say, hey, like, we're hearing that this particular nursery or this particular birthing hospital, parents are coming in and saying they're screening our kids 3 and 4 times. So then they have a really nice follow-up program and good communication with the hospitals so that they can do ongoing education to make sure that we're really adhering to that 2 screen rule. That's a good question.
Okay, we have another one. Should kids with limited language, expressive language delay, nonverbal kids with developmental delays see audio every year for follow-up, or how often, assuming there are no other issues?
That's also a really great question. So I think the answer is sometimes they should see audiology every year. We're going to do a really thorough review of their history. If there's a history of ear infections, we're definitely going to want to see them a little more regularly for maybe a little bit longer than a kid who's not had an issue. We're going to educate the parents about signs and symptoms of hearing loss if they come in and their child has a normal test, and we're going to encourage them to follow up. But I don't think, as a general rule, if you have a kid with a speech delay, that they need to be seen annually. If the child is able, they can participate in a hearing screening through the PCP office, and that is sufficient for monitoring. Those are really good questions. Thanks, Julia. If they cannot do in-office screens, you are welcome to send them to us. Again, we will review their history, their risk factors. If we get a normal test, particularly if we have to go to a sedated ABR, I'm thinking now for like our population of kids who are severely autistic, if we can document normal hearing in both ears, I feel like that can be kind of tricky, because if they don't have any risks for hearing loss, we don't necessarily want to sedate that kid once a year, because so there I think is a little bit of a trade-off there. And I think we take that on a case-by-case basis.
I'm not seeing any more questions come in.
Well, thank you everybody for your time today. It's only 12:52, so I see that I lived up to my usual talk fast, which is helpful. But please reach out to myself or any one of my colleagues if you have questions. We're available via email. We're available through secure chat, in basket, whatever you need. We're always happy to help. And I hope all of you have a wonderful holiday season.
Thank you so much. And we'll put your email in the chat as well so everyone has it.
Okay.
Thank you so much for being here today and for taking the time to present for us. Really appreciate it.
Glad to do it. Thank you.